some examples of some 340B business models, as well as a discussion of the definition of patient and the use of contract firearms. Then we'll turn to the current compliance and enforcement environment, which will include a discussion of the impact of healthcare reform on the 340B program, the recertification requirements, as well as the new audits of the covered entities, and some tips for ensuring compliance with program requirements. So I wanted to start by giving just a background on the 340B drug pricing program for those of you who might be less familiar with the program. The program was started in 1992 after the enactment of the Medicaid drug rebate program. It's a federal program and it's operated by the Office of Pharmacy Affairs in the Health Service Resources and Services Administration, which is known as HRSA. Under the program rules, drug manufacturers are required to provide significant discounts to participating covered entities on covered outpatient drugs. It's important to note that the covered drugs are only outpatient drugs and not those administered in an inpatient setting. The program was intended to provide relief to specific facilities that provide care to the medically underserved. It's a requirement of the program that manufacturers that are participating in the Medicaid program must also participate in this 340B drug pricing program. The manufacturers must provide discounts on the outpatient drugs purchased by the participating in government-supported facilities, which are known in the program as covered entities, and we'll talk more later about who specifically these covered entities are. There is a ceiling price that's established by statute, and it's linked to the price paid by Medicaid, which includes significant discounts. For brand drugs, it's the lower of the manufacturer's best price, or 15.1% off the drug's average manufacturer's price. So in general, the drugs may be billed to payers at the retail price. And the statute does not specifically prescribe how the savings from the program must be spent by the covered entity. However, that said, there have been recent congressional inquiries into hospitals' use of their 340B savings. Senator Grassley actually sent a letter just last month to 3 North Carolina hospitals where he inquired about the use of their 340B revenues. He sent questions to them asking for responses and documentation regarding whether those hospitals are passing savings on to their patients or just subsidizing their bottom line operating margin. Just to read you a quote from his letter, he said, if nonprofit hospitals are essentially profiting from the 340B program without passing on the savings to patients, then the 340B program is not functioning as intended. And he actually asked for specific information from those hospitals about how they invested the savings to benefit uninsured patients. So again, this is not necessarily specifically in the statute, but it seems to be a current focus of Congress. It is somewhat supported by the language in the congressional report when the program was first implemented back in 1992. There was some language in those reports about intending to provide these discounts in order to help these entities stretch their resources and allow them to reach more patients and provide more comprehensive services to patients. A few notes on the 340B and the Medicaid program. Covered entities may not receive a 340B discount for drugs that are subject to a Medicaid rebate. Providers are required to let person know by providing their Medicaid billing number when they enroll in the 340B program if they plan to purchase and dispense 340B drugs for their Medicaid patients and bill Medicaid. They have to follow procedures that are established by the specific state Medicaid agency. State Medicaid programs can require covered entities to carve out Medicaid patients from 340B since the state can claim the drug rebate. The programs may also allow the covered entities to use 340B drugs for Medicaid patients and reduce the Medicaid payment to the covered entity. In addition, a program may allow covered entities to use the 340B drugs for Medicaid patients and pay an increased dispensing fee. Now we're going to turn to some of the specific requirements of participation in the program, and I'm going to turn it over to my colleague now.
Okay, thank you. So now that Elizabeth has described some of the benefits of the 340B program, I'll be discussing how to qualify to participate in the program, and after that I'll discuss what can be done with the 340B drugs. The basic rule, the 340B, is fairly simple. In order to be a covered entity, you've got to meet one of the categories listed in the statute. You must meet all of the conditions within any one of the categories, like the groups, like the covered entities on this and next few slides in different buckets. The first one is the health center bucket. That includes FQHC as well as FQHC lookalikes. There are Native Hawaiian health centers, tribal and urban Indian health centers. A separate bucket is program grantees under the Ryan White program. This is the Ryan White statute is a statute that provides grant funds for individuals with HIV and AIDS. That includes not only clinics, other grantees, but also the state aid drug assistance programs, which every state operates. Another bucket is specialized clinics that offer particular services to individuals with who might be medically underserved. That includes Title X family planning clinics, STD clinics, comprehensive hemophilia diagnostic treatment centers, tuberculosis clinics, black lung clinics. Each of these clinics and other companies are eligible to purchase drugs at the discount price. And the largest category, or one of the largest categories for 340B, is covered entity hospitals. Since the initiation of the program, 340B has applied to disproportionate share hospitals that meet certain criteria. In order to qualify, you've got to have a Medicare fixed percentage of greater than 11.75%. And in addition, you've got to meet the ownership criteria, which means you've got to either be publicly owned or operated, have been formally granted governmental powers by state or local governments, or have a contract with state or local governments to provide health care to low-income indigents. And the low-income indigent means individuals who are, include individuals who are not eligible for Medicaid. And as a third and final criteria for disproportionate share hospitals is that they are prohibited from purchasing covered outpatient drugs. That is, the drugs that are subject to 340B discount to a group purchasing organization. More recently, in 2010, the Federal Healthcare Reform Law added certain new hospital covered entities to the 340B program. These new entities include children's hospitals, freestanding and cancer hospitals, critical access hospitals, rural referral centers, and sole community hospitals. As you can see on the screen, these hospitals each have their own disproportionate share requirements, with the exception of critical access hospitals, and they must also meet the ownership criteria that apply to traditional hospitals, which must be owned publicly, be a public hospital or formally granted public governmental powers, or be a non-profit with a contract to provide care with indigents. So meeting the statutory criteria is not sufficient. It's necessary but not sufficient to participate in the 340B program. If you want to participate, you need to notify the Office of Pharmacy Affairs or Oversight of your intent to participate. The specific enrollment procedure is different for different covered entities. Generally, it's fairly simple. You need to submit some kind of form and certification to OPA. Fairly recently, this new rule took effect October 1st of this year. The new rule was that you can only register a new covered entity or a new location of a covered entity during the first 2 weeks or first 15 days, I guess, of each quarter. And if you do that, then your registration will be effective at the start of the following quarter. So if your program gets up and running and on November 1st, you'll have to wait until January 1st to register, and then it will be effective on April 1st. And until you're registered, you will not be eligible for the 340B discount. And the last bullet on the screen we'll be talking a bit more about later. Maintain a covered entity database that lists all of the eligible entities and locations that utilize 340B drugs within the eligible entities, and all the contract pharmacies that covered entities that contract with. This database is where manufacturers look to determine whether or not an entity is eligible for the discount, so it's very important to maintain that database. Okay, wanted to go over a few models, business models that involve the 340B program to kind of illustrate some of the complexity in determining 340B participation. The stuff that I just mentioned about the different categories of covered entities is fairly straightforward. You either meet the criteria or you don't, and you're either enrolled or you're not. But we do get a lot of complex questions about what that means once you are participating. And so the model on this slide, the next three slides, are intended to illustrate that. I do want to emphasize that these models are necessarily abstract. They're not just any fact pattern, and individual fact patterns can lead to different results in certain circumstances. So it's important to analyze each circumstance differently, but these four slides are here to illustrate certain basic rules the person has published. So on this slide, this scenario is a basic health system in which a certain parent company owns and operates a hospital, a clinic, and then a separate clinic that qualifies for 340B status. The hospital and the first clinic do not qualify for 340B status. And HRSA's rule is that common ownership is not enough to grant the hospital and the first clinic to access to 340B drugs. The rule is that only the part that qualifies the covered entity will be eligible for 340B drugs. That's the case even if the parent purchases drugs for all three of these facilities in bulk. In fact, HRSA would require the parent entity, if they do that, to establish separate purchasing and testing records for that 340B clinics in order to segregate the 340B drugs. So another common arrangement is when a 340B covered entity hospital desires to use 340B drugs at a series of clinics that it operates. As we discussed in the previous slide, common ownership of the clinics by the hospital is not sufficient to justify the use of the 340B drugs at all the clinics. HRSA has stated that only clinics that are operated as an integral part of the hospital will be able to access the hospital's 340B drugs. And the test HRSA has developed for determining whether a clinic is or is not an integral part of the 340B hospital is to ask whether the clinic is listed as a reimbursable center on the hospital's most recently filed cost report. Now, in order to get listed on the hospital's most recently filed cost report, generally the rule is that you need to qualify as a Medicare provider-based clinic and meet all Medicare provider-based rules. If you do meet those rules, then generally you can be listed on the hospital's cost report as a reimbursable center, and you can access the 340B drugs. However, if the 340B hospital offers a freestanding clinic that does not meet the provider-based rules, it would generally not be on the cost report and would not have access to the 340B drugs. The third bullet on the screen is important to emphasize because HRSA's interpretation of its rule it really does rely on the most recently filed Medicare cost report, and this interpretation has led to significant delays for facilities. If a hospital opens up a new clinic, and they open up the new clinic in July, and their fiscal year is over at June 30th, they may not have any costs to report until June 30th of the following year, and the cost report is not usually filed 5 months after the end of the fiscal year, which means that in the interim period, that clinic cannot use access to 340B drugs and would not be considered part of the hospital, even though it may actually meet the provider-based rules, which just hasn't yet been listed on the cost report. Another common arrangement we get questions about would be the relationship between a 340B hospital and its local physician offices. These may be physician offices that are across the street from the hospital or closely co-located. Some physicians are likely to have privileges at the 340B hospital and have close relationships with the hospital. However, the rule in the statute is that physicians do not qualify as covered entities under 340B. The 340B program is only for facilities, mainly clinics or hospitals. And so again, you're going to look at the same rule we discussed in the previous slide, which is if the medical office is not a reimbursable center on the hospital's most recently filed Medicare cost report, then the medical office is not eligible to purchase 340B drugs. If it does happen to be operated as a provider-based clinic of the hospital, then it would qualify. And so that is a fairly clear rule, but there is some complication, and we have seen arrangements that lend some complexity here. That's indicated in the bottom bullet on the screen. So individuals who are paid to the 340B hospital are allowed to receive 340B drugs purchased by the 340B hospital. Now, in many cases, those patients will also be seen by the physicians who work at the office that may be across the street. So it's important to really be careful and to distinguish who is the patient of the hospital and who is the patient of the doctor. And in some cases, you can be both. And if you're a patient of the hospital, then you're eligible for 340B drugs. The last model we wanted to discuss involves two separate hospitals, one of which is a 340B covered entity and one which is not. In many cases, we've received questions from hospitals that are not 340B entities. They're interested in affiliating or undertaking some kind of joint arrangement in which the 340B hospital can bring the cheaper drugs to patients of the non-340B hospital. As I've gone over, the rule is that 340B drugs are only eligible for the covered entity hospital, not the non-covered entity hospital. So that does not mean that the two hospitals cannot collaborate to create a clinic in which both hospitals benefit and the patients receive the 340B drugs. In order to get 340B drugs, this affiliated clinic would need to be listed as a reimbursable center on the 340B hospital cost report. But in some cases, depending on your state licensing laws and compliance with the provider-based rules, it may be possible that affiliated clinics be located adjacent to the non-340B hospital. It could potentially be staffed by physicians who are employed by or under contract with the non-340B hospital. But there could be other joint arrangements that benefit the non-340B hospital. And now I want to talk about what is basically the principal rule in the 340B program. The principal rule is that covered entities that purchase covered outpatient drugs at 340B prices are prohibited from selling or otherwise transferring those drugs to persons who are not patients of the covered entity. This rule is intended to keep the benefit of the 340B program with its intended audience. And it prohibits both the dispensing of drugs to individuals on a retail basis. For example, if an individual just walks into your clinic or your hospital and has no other relationship with them, if the clinic or the hospital, that individual will not be considered a patient and should not be given 340B drugs. And it also prohibits transferring of the drugs to other facilities. For example, a covered entity hospital should not transfer drugs to the medical office across the street unless that medical office is considered part of the 340B hospital. Because this term patient, the prohibition on diversion depends on whether or not an individual is a patient of the covered entity. There's a lot of pressure on what this term patient means and how you qualify as a patient of a covered entity. But the 340B statute does not define who is or who may be a patient. A person has put out a regulatory definition that is controlling. Their definition was published in 1996, and I'll go over that definition on the next few slides. But it's important to note that in 2007, HRSA proposed significant revision and revising of that definition in a proposed rule, but the proposed rule never finalized. So as a result, that 2007 rule has never taken effect. But it does indicate that HRSA has attempted and may still be interested in revising the definition of patient. And you can see on the screen that the GAO, that's the Governmental Accountability Office, as well as members of Congress, have sent letters to HRSA and issued other documents directing or advising HRSA that they need to do more specific definition of patient. So we do expect that there will be a new definition of patient coming out at some point in the future, but at this point, it's anybody's guess what that definition will contain. So we're still going to rely on the October 1996 definition. So there are three prongs to the definition of patient. In fact, it needs all of them. The first requirement is that the covered entity has established a relationship with the individual, that the covered entity maintains records of the individual's health care. When they first published this definition, they received a contact why they used the term records of the individual's health care. And the question was, does that really just mean the patient's medical record? And the answer was, yeah, it generally does mean medical records, but they didn't want to limit it just to medical records. But generally, if you covered entity does still work the patient's medical records, you will be fined for the first prong of this definition. The second prong is the individual has to have received healthcare services from a healthcare professional who is either employed by the covered entity or provides healthcare under contractual or other arrangements, for example, referral or consultation, such that responsibility for the care provided remains with the covered entity. And third, the individual must receive a healthcare service or range of services from the covered entity, which is consistent with the service or range of services for which grant funding or SQHC lookalike status has been provided to the entity. And disproportionate share hospitals are exempt from this requirement. The patient of disproportionate share hospital is exempt from that requirement because they don't have a grant that would define their scope. This definition was published before the Affordable Care Act had the other hospital covered entities, but there's a strong presumption that other hospitals will also be exempt from this requirement because the requirement doesn't make much sense. But if you are a clinic, for example, if you're a TB clinic or a family planning clinic or a hemophilia clinic, this third prong limits individuals who qualify as patients of a covered entity to individuals who receive TB services or family planning services or hemophilia services, respectively. And the last note is an additional caveat that this person has published. The individual is not a patient of a covered entity if the only healthcare service the individual receives from the covered entity is the dispensing of a drug or drugs for subsequent self-administration or administration of the home. I believe this requirement was intended to prohibit covered entities from making the argument that, oh, this individual is a patient of my hospital because they came to my hospital pharmacy. Person requires something more than that. They require actual provision of medical services in addition to the drugs. So as I mentioned, there's a lot of pressure on this definition of patient. It's the linchpin of what can be done with 340B drugs. As you may have thought to yourself, and I'll go over those problems, there's a lot of gray area in how you satisfy, particularly the second requirement that says the covered entity must maintain responsibility for the care of the patient. When you actually think about the variety of healthcare arrangements that have popped up around the country, there's a still amount of complexity in determining whether they met that second prong or not. So I looked at just a few examples of gray areas that we've seen. Some of these are gray areas that were addressed in the 2007 proposed definition of patient, but since that 2007 definition was never finalized, the guidance remains unclear. So the first example, this is like an only exhaustive list, and the first one I want to discuss are situations which a covered entity patient, that is, does qualify as covered entity patient, they receive certain care from that covered entity, and then go outside and receive care from another provider, and then return to the covered entity pharmacy to fill their prescription. In that case, the covered entity is going to have a record of their care, and they will have provided services to the individual, but the specific thing was provided that led to the prescription being filled may have been provided by someone unaffiliated with the covered entity. And HRSA has said that in certain circumstances, covered entities may fill those prescriptions as long as the prescription bears a proximate relationship to the follow-up care. For instance, the covered entity refers a patient to a specialist that orders a drug to control conditions and supplement instruction. That sort of could be something at the end of the date and sound. For the patient, treated and your company name. After the first name, your last name, and your company name, press the pound key and you'll be directly connected to your account. Fill all prescription drugs from any other condition.
Louis, CDCR.
The exception is unclear. HRSA has made those statements about the proximate care relationships in some regulatory guidance, and it's just not clear whether it's important or not. Second,
as you state your name, please press the pound key.
Lipton Louis.
Issues that are not done on the covered entity's clinic or hospital campus. These would be examples in which the covered entity actually sent its physicians out to provide care at other sites, maybe at a mobile clinic, maybe at a prison, maybe at a health fair. These are situations in which you can make a strong argument that the covered entity does have a relationship with the individuals treated. The individuals treated are patients of the covered entity. However, HRSA has begun relying on that cost report test
for hospital covered entities. So if the care is not provided at a cost support facility, then HRSA could object to those arrangements by arguing that the care is provided outside a covered entity. Individuals cannot be considered patients of the covered entity. A similar scenario applies in the situation I mentioned earlier, in which a hospital covered entity might open up a new facility, a new provider-based clinic, but there is a lag time before that provider-based clinic gets added to the hospital's cost support. So HRSA's rule is that provider-based facility is not part of the hospital until it gets added to the cost support. But of course, that provider-based facility will be closely integrated with the hospital, and you can make a strong argument that the individuals treated there are patients of the hospital because their care is provided by employees or contractors of the hospital, and the hospital would maintain the medical record. However, it is being provided at a site that HRSA considers outside the covered entity. And the third gray area one to discuss would be the treatment of services referred by the covered entity to an outside provider. We've seen questions arise in these situations in which a covered entity, if you go back to the second part of the definition of patient, you see in the parenthetical here that individual wants to seek healthcare services from healthcare professionals either employed by or other arrangements with the covered entity, for example, for consultation. And so it is there's a lot of uncertainty about what that referral for consultation means. In 2007, HRSA's proposed definition would have clearly prohibited covered entities from considering individuals patients if the only oversight a covered entity has of the care is limited to like a case management structure. HRSA described these as loose affiliation networks in which they claim that certain covered entities were kind of being run around the definition of patient by maintaining limited administrative control over the care provided patients. The actual care was provided by individuals who have no particular relationship to the covered entity. And HRSA would have prohibited that in 2011, but that's the guidance that were finalized, and so the rules have not become any more clear in the meantime. So as we mentioned, there are considerable risks associated with the definition of patient, and as opposed to we'll speak to later in the presentation, the compliance enforcement environment is increasing here. But there is what's done with guidance on what the definition of patient is. We're in a situation now in which law auditing and enforcement everything, but the gray areas that HRSA has recognized are in the definition of patient and not to clarify it from there. We do expect more guidance next year in the future, and as I mentioned before, the accountability officer has advocated for HRSA to provide and use more specific definitions of a 340 patient. All right, before we turn it over to Elizabeth to talk about the compliance, I think it's essential to talk a little bit about one of the considerable new opportunities in the 340 program, which is the greatly expanded use of contract pharmacy arrangements. So as I've gone over, the 340B statute limits purchasing of 340B drugs to covered entities and limits covered entities to using those drugs for the covered entity patient. However, the 340B statute does not say how the 340B covered entity can provide 340B drugs to its patients, and in fact, HRSA has expressly allowed covered entities to use either an in-house pharmacy to dispense drugs or to contract with a retail pharmacy. So the idea is that in order to get around the prohibition on a diversion of the transfer of drugs to individuals who are not a covered entity by arguing that the covered entity, the contract pharmacy, covered entity, and the covered entity retains title and control over the purchasing and dispensing of the drugs by the retail pharmacy. And HRSA has expressly allowed those arrangements since back in the mid-90s, but in 2010, HRSA issued new guidance expressly allowing covered entities to utilize multiple contract pharmacies. And as a result, there's now no limit on how many contract pharmacy arrangements you can have. You can have 1,000, you can manage them. And as a result of this new guidance, we've seen retail pharmacy chains, including Walgreens, CVS, Rite Aid, as well as some smaller groups that target themselves specific groups. I've spoken with some smaller groups that act as contract pharmacies just for oncology drugs, for example. So these pharmacy chains have moved into the 340B world and are advertising contract pharmacy services to covered entities as a way to expand access to 340B drugs as a covered entity, and in some cases they can lead to significant new revenue for the covered entity depending on the size of the markup, because the covered entity does receive the advantage of the markup even if the drugs are spent by the retail pharmacy. So a contract pharmacy arrangement is generally what first called a ship-to arrangement. Is generally a ship-to arrangement in which a covered entity purchases in the case of the drugs. Frequently these prices are contract manufacturers, but the drugs are billed to the contract pharmacy, which maintains the contract pharmacy will then bill payors, and the contract pharmacy will then bill payors and patients on behalf of the covered entity. Any revenue that is received by the contract pharmacy should be considered to belong to the covered entity because they are the drug patient belong to the covered entity and they are the patient. But the contract pharmacy will negotiate a fee from the covered entity. Generally, the way I've seen these arrangements, the pharmacy will bill the contract pharmacy will bill a third-party payer. That's what they normally do, but then we'll remit the payment minus the fee for authorized in their contract with covered entity, which results in administrative fairly wage by transfer these funds around. And it is important for the person who wants to serve rules and covered entity have the ability to establish use case certification. The covered entity does maintain some control over, for example, the payment, this payment provides, and that way they can tag along the benefit of the 340B discounts to patients, even if they're picking up their goods from a 340B contract pharmacy. So it is essential that the contract pharmacy and the covered entity establish an adequate mechanism to screen individuals from the contract pharmacy with a prescription in order to determine if they qualify as a patient of a covered entity and to track the ordering, receiving, and dispensing of 340B drugs. The person does require, and this has been a case, they have not provided much guidance on the kinds of arrangements they would look for or that it would consider to be adequate. Generally, the rule now is that it's always the covered entity's responsibility to maintain compliance. So the covered entity has that obligation, and so if it doesn't have an adequate mechanism to ensure that when these drugs get purchased by the contract pharmacy on their behalf, they are not being diverted to individuals who are not patients, or that duplicate discounts are not being claimed with the Medicaid program. There are additional requirements for contract pharmacies that I have not gone into in this slide, but it is essential that you have your contract pharmacy arrangement used by counsel in order to ensure that they meet those regulatory requirements. And just beyond those regulatory requirements, it's important to review your program from a comprehensive perspective to determine what it would look like in the event of an audit, and to determine whether there is any opportunity for leakage of these 340B drugs into those who should not be receiving them. Alright, well, that's a nice transition to the Elizabeth portion of the presentation, which will talk about compliance and enforcement. But before we get there, I'm going to announce for individuals in New York, this is your CLE code. It's WN6ST. If you're not in New York, you can ignore that.
Thanks, Neil. So as Neil mentioned, we're going to turn now to the compliance and enforcement environment, which both of us have alluded to earlier. The environment, as we may know, has been rapidly changing in about the past year or so. Historically, there had not been a lot of enforcement in this program. They relied on self-policing by the covered entities, subject to potential audits by HRSA and manufacturers. However, recently, in the last couple of years, healthcare reform, as well as inquiries by both Congress and the GAO, have led HRSA to take a more active oversight role versus take a more active oversight role.
and expanded access that led to increased risk. Just to give you some more specifics here, as to how it came about, in 2011, the GAO that called for a very comprehensive report that called for increased federal oversight of the 340B program, and it concluded that the current, at the time, the existing oversight was inadequate, that they were not doing their job. They recommended a number of specific enforcement actions, such as HRSA audits, and a more specific definition of patient. As Denise mentioned, we have not yet seen that specific definition of patient adjusted, but we were awaiting that. We have, however, seen these new audits, which I'll talk about momentarily. Additionally, since following the GAO report, there have been a number of congressional inquiries. Earlier this year, in the spring, there were congressional inquiries issued to the Hospital Pharmacy Association, as well as the manufacturing organization, where Congress specifically expressed concerns with the validity of the program and asked these organizations for a number of documents and specific guidance that they have provided to their members with respect to the 340B program requirements and their thoughts on how to improve oversight. The program's oversight. Additionally, earlier this summer, there was a congressional inquiry sent to an Alabama hospital regarding some allegedly inappropriate changes the hospital has made in their admission process in order to achieve 340B savings. So basically moving patients to an outpatient status in order to achieve savings. And then we mentioned just last month, the North Carolina hospital got the letter from Congress asking them to respond on their specific types of 340B savings and whether those were being passed on to Congress. I'm sorry, to patients. So, our entities are sort of getting it from all as a person now. They're really starting to crack down in a way we had never seen before. So, the first thing that happened was the healthcare reform, and there is very significant sanction authority added for 340B violations. Previously, as I mentioned, mainly self-policing, and the consequence really were the potential repayment to manufacturers that this was primarily enforced by HRSA. Actually, in the 2011 GAO report, the GAO said that according to HRSA, the start of the program in 1992, there had only been 2 covered entities terminated from the program for very egregious violations. So, currently under the healthcare reform statute, the sanctions include the forfeiture of the 340B discounts to the manufacturer, as well as applicable interest on monetary penalties if there were knowing and intentional violations of the program rules. Additionally, if it's found that the violations are systematic and egregious, so, if these are regular violations and are egregious in nature, the covered entity can be disqualified from the program. And it's possible that when they're disqualified, there could be a period of years that they are prohibited from re-entering the program. So obviously that can have very serious financial consequences for the covered entity. Another important thing to note is that when there are violations found, HRSA now has the authority to refer the matter to the OIG or other federal agencies, like the FDA, for instance, for further review of the matter. So they could look into whether there were Prescription Drug Marketing Act violations or other violations of federal laws. So, as I mentioned, the Affordable Care Act amended the statute as well as with respect to their sanction authority. They also require HRSA to develop specific procedures to allow and require the covered entities to regularly update, meaning at least annually, their information about their eligibility in the program and their compliance with program requirements. And I'll get to those in a little bit more specifically. The goal of this was to ensure program integrity and compliance, as well as transparency and accountability on the covered entities, to ensure that the information that's in the database, as Anil mentioned, which is relied on by the manufacturers as well as HRSA, is accurate and complete. HRSA emphasized the importance of maintaining this accurate information in their database used by the manufacturers. It is publicly available, which included the website here for your convenience. HRSA says that all the sites need to be listed that are using the 340B drug, and as well, as Anil mentioned, all these contract pharmacy arrangements must be registered with HRSA as well.
So, as I mentioned, the healthcare reform requires this.
So, as I mentioned, the healthcare reform requires eligibility, a new annual process to confirm eligibility and compliance. It's called the Recertification Requirements. It started this past spring, so I'm sure many of you have gone through this process, or will have to if you're new covered entities. In the spring, the covered entities began having to update their information in the database and certify their compliance with the 340B program rules. The Lardner programs, SAD and TB, is family planning clinics, as well as hospital, and they were completed this year. FQAs are anticipated to be completed beginning of next year.
So I thought it was actually important.
To go with the registration requirements. The guidance published by HRSA on recertification. So the covered entity has typically had signed identification and submitted that all the information on the 340B database for the covered entity is complete, accurate, and correct. They also, this is one of the important, they have to certify that they continuously met all the 340B program eligibility requirements. Additionally, the covered entity has to attest that they comply with all the requirements and the restrictions of the 340B program, and that includes the statutes, the regulations, guidelines on the discounts, prohibition on discounts under Medicaid, as well as the prohibition that Anil went into detail on transferring drugs to non-patients of the covered entity. The covered entity also has to certify that they maintain auditable records that show their compliance with those requirements with respect to duplicate discounts and transferring drugs to non-patients. Additionally, they have to attest to the fact that they have systems and mechanisms in place to ensure ongoing compliance with those same requirements related to the discounts and the patients of the covered entity. Additionally, if a covered entity uses a contract pharmacy arrangement, that in the sense of the contract pharmacy arrangement is being performed in accordance with the program requirements and guidelines, including the fact that the covered entity has enough information from that contracting pharmacy to ensure compliance with the legal requirements, and that the covered entity has an appropriate methodology to ensure compliance. For example, that they are auditing the covered entity, the contracting pharmacy to ensure compliance with program requirements. Additionally, the covered entity has to acknowledge that it's responsibility to contact the Office of Pharmacy Affairs as soon as possible if it knows that there is a material breach of any of those requirements that I just discussed. If they don't notify OPA in a timely fashion, they have to acknowledge they may be required to pay out manufacturers the difference between the discounted price and the non-discounted price. Just another thing to mention is that the 2010 guidance that created the new rules for multiple contract pharmacies also talks about that requirement that covered entities immediately notify OPA if there's any breach of the program requirements and explain how they've remedied that breach. And obviously, with a certification like this to a federal government agency, it's important that it be accurate because, of course, there's laws, governing false statements to government agencies. So also wanted to mention, which we brought up before, that HRSA is now doing audits of covered entities, and all the covered entity types may be audited. In this year, in 2012, HRSA conducted over 50 audits, and they began conducting both random and targeted audits. The random audits focus on specific program types, and they consider higher risk. And they said that the higher risk program types are larger volume, so a larger volume of 340B purchases, the complexity of their administration and the use of contract pharmacies. Targeted audits may come from audit entity, data entity, manufacturer complaints, or a self-reporting of a compliance problem diversified a covered entity. HRSA is also in their guidance on audits, they have said that the findings of the audit may be sure to refer matters to the Inspector General or Department of Justice, so these need to be taken seriously, and covered entities need to prepare for them. HRSA actually recently did a presentation, and they specified what they're looking for in the audit. They are going to verify the continued eligibility of the covered entity. They will expect to review the covered entities and see how they're actually being operationalized to prevent conversion and duplicate discounts. They also will review those internal controls. They also will review those internal controls that are in place to prevent those diversion and discounts. They also will review the contract warranty compliance. So they may want to see your contract. They may want to look at the specific arrangements and understand what the procedures and internal controls are with respect to that contract warranty arrangement. They also may see tests of specific transactions and take a look at samples to see that the program is working. Additionally, they are rolling into 8 audits or 3 audits site visits that are required for non-federal entities that expend more than $500,000 a year. So we're going to roll into those some 340B compliance questions. They're going to be, again, reviewing program policies, procedures, and internal controls and records in conjunction with these audits. And those are going to start next year. The supplements that are used for those audits are going to be updated to include reporting with the question. And just a quick note here as well, the HRSA audits, of course, manufacturers can still audit covered entities if there are concerns related to compliance with the covered entities, prohibitions on drug diversion or duplicate discounts. The manufacturers have to submit an audit work plan to the OPA prior to conducting those audits. So lastly, we just wanted to have a couple slides here with some recommendations to help ensure compliance and also help prepare for the recertification processes and potentially the targeted or random audit. So 340B covered entities should ensure that they have a 340B compliance plan in place, and that plan should be robust and cover all the applicable definitions and program requirements. The covered entities should ensure that all the employees involved in the 340B program, so obviously, legal compliance, pharmacy members, anyone else working in the program should be trained on the policy and should understand the compliance plan. Also, we recommend that the covered entities review their program compliance regularly and certainly prior to the recertification period where they have to recertify their program compliance requirements. Also, the covered entities and their contract pharmacies must make sure that they have accurate records of documents. Make sure that they have accurate records of document compliance with the program requirements. As I mentioned, these records are subject to audits by both the OPA and the manufacturers. So we recommend that the covered entities have specific procedures and system controls in place to ensure compliance with the rules regarding diversion and duplicate discounts, and those should be developed and regularly reviewed and updated. It's important, like we mentioned, HRSA may be updating their guidance, so as they do, the procedures, systems, the compliance plan may need to be updated to reflect any of the guidance that does come out. Basically, we recommend covered entities have a complete audit trail from the purchase of the drug and the pickup of the patient, you want to be able to show that it's compliant all the way through.
Also, we
recommend paying special attention to mixed-use settings. So if it's not in hospitals, if there are settings where inpatients and outpatients get drugs, like an emergency room or an oncology clinic, it's important to look at the procedures in place to ensure only appropriate outpatient drugs are being used under the program. And also important, as Anil discussed earlier, with these relationships within the hospital or healthcare system, it's important to focus on those relationships and how the drugs are being distributed when there are entities that are both 340B covered entities and ones that are not 340B covered entities within the same healthcare system. Also, as you mentioned, covered entities should establish procedures to periodically audit their own records and the records of contract pharmacies. And finally, really important to just continually check the database and if changes are made within the entity and the healthcare system to keep that information current on the OPA database. So this is the end of our presentation. As I mentioned at the beginning, we appreciate your feedback, so please take a few minutes to complete the survey. Before we open it up to questions, I wanted to provide the final CLE code for those of you in New York. That code is PGIF7. Again, to repeat, PGIF7. So thank you all for your time today. We'll now open it up for the questions.
Thank you. Ladies and gentlemen, if you have a question, please press *1 on your touchtone telephone. If your question has been answered and you wish to remove yourself from
Crap, I didn't want to do that.
Okay, now I think I can remember where this place was. There we go.
So this is Becky. I have about 4 after 2, so I know everyone's very, very busy.
Hello, Becky?
Hi.
It's Mo. Man, what am I hearing?
I'm on a CHI conference call.
Oh, why don't I call you back and you call me when you're off the CHI conference call?
Okay, I'll give you a call back in a little bit.
Thank you, bye.
All right, thanks. Bye.
Yeah, and I don't want to find this without this. Right here? I don't want to find that. Oh.